morning, good afternoon, good evening, everybody. I'm Larry Knowlton from Knowlton Diagnostic and Treatment Center. We're here today to talk to you about an innovative program that was developed in collaboration with the county, the managed care and provider in Cambria County, Pennsylvania. And it's called Enhanced Community-Based Treatment Team, and it was formerly known as just CBIT, Community-Based Intensive Treatment Type Program. And what we're looking at doing is leveraging our system transformation and looking at value-based strategies to solve these delivery system pain points. I'd like to introduce our presenters today, myself, Larry Knowlton, also Monica Collins from Magellan Behavioral Health, Senior Director of System Transformation, Tracy Selak, our Cambria County Mental Health Administrator, and Ashlyn Zanke, the Supervisor for the eCBIT program of Knowlton Diagnostic and Treatment Center. What we're going to do here today are try to meet some learning objectives, and the first one is to recognize how system transformation and value-based strategies can be applied in order to develop creative models in a fragmented fee-for-service system. Also, what we're looking at is recognizing how providers and payers can partner in a way to do some creative, innovative program modeling and implement it within a system, especially in a rural delivery area. We also want to understand how creative care models can reduce readmissions, improve aftercare treatment, and the reduction in readmissions, and also just decreases system fragmentation of delivery. So in conclusion, what we want to do is discuss a review of a truly recovery-focused system of care. And what I mean by that is we really want to see recovery, and that's going to be our focus. So you'll see this later in the data to show how these people are improving in their areas of needs, risk, also in their strengths, and also transitioning from these higher levels of care so they're not stuck or fixated in this level. Our agenda today here is the following. We're going to introduce eCBIT and CBIT, and we'll talk about the differentiation, but we'll talk about how this program evolved and started many years ago, actually. The model, we'll discuss it and the key components and what makes it successful. The multidisciplinary approach, integrated healthcare. We'll also look at the metrics and measures of focus. These will be important things for managed care, you, the provider, and the system, as well as the county. We want to make sure what we're implementing is effective and valuable. In this way, we can actually prove and demonstrate the benefit to everybody involved, from the client to the provider, to the payer, to the county and the community. And what you'll see these benefits through the outcomes and results. And we'll show some pretty significant results that you're seeing in a program dealing with the most severe mental illness. And the other thing that is important that we've been examining for the past 10 years, quite honestly, is the payment model. And Magellan Behavioral Health really has demonstrated how to partner with the community, the county, and the provider in developing an effective payment model that helps reduce and look at some of these pain points for the state and the managed care, but also have the provider, and in the end, benefiting the client.
As a brief introduction and background to CBIT, or Community-Based Intensive Treatment, we need to go back in Cambria County's history. Cambria County has traditionally never had a community-based treatment program that was comprehensive and inclusive of a variety of services. In 2008, the state did issue an RFP for the ACT program, a pilot to start an ACT program with 3 community providers in the state. And Knowlton Diagnostic in Cambria County did respond to that RFP. Unfortunately, the RFP was never fulfilled and realized by the state, and so we never were able to get an ACT program up and started. As many of you know, ACT programs are very cost prohibitive because of the inclusion of psychiatry and medical services such as nursing, PAs, and so we've never been able to get to a place where that an ACT program would be viable and successful in Cambria County. Late 2012, 2013, what we started to see was that the Pennsylvania state hospitals were seeing a influx of individuals in need of the state hospital level of care, and they were quickly reaching their capacity and actually exceeding the bed capacity for those facilities. We additionally were seeing backlogs of wait lists in the community hospital of individuals who are awaiting admission to the state hospitals and would languish in the community setting until a bed became available at the state hospital level. Counties were then charged with coming up with transition plans for these individuals at the state hospital level to return to the community. The turnaround time that we were experiencing from admission to discharge had been significantly lessened. Historically, it was 6 months or more. During this time, we were seeing people's length of stay an average of 3 months or less. And so what our concern was is these individuals had had significant medication changes, and they were adjusting to those changes, as well as they were in their infancy of their own personal recovery. And so we were trying to link them with the existing services, which at the time we had a wide array of outpatient community services, including adult partial hospital program, a mobile and site-based psychiatric rehabilitation program. We had numerous traditional outpatient providers, 3 blended case management providers, 3 peer support providers. So we had a lot of those standalone services, all of which were designed to engage individuals on a more individual and intensive level. But despite those efforts, we were not seeing individuals succeed in the community for long periods of time when they were discharged from the state hospital. They were quickly decompensating despite the community efforts, and they were winding back in the community hospital, the acute unit, awaiting a return to the state hospital level of care. One of the big challenges that we had with individuals coming out of the state hospital was linking them with community providers for those services. Although we had numerous providers, they weren't always able to accommodate individuals because of capacity to bring them into their outpatient programs. And additionally, there was a reluctance to serve some individuals because of the history of noncompliance and follow-through with treatment at that particular provider. As the county administrator, I recognized that there was something missing in our system. Not unique to me. I think many counties were acknowledging that there was a challenge serving this population with a change in the time frame in which we were having to quickly engage them and serve them. And so at that time, I had remembered that Knowlton Diagnostic had pursued the ACT RFP, and so I outreached to Dr. Knowlton, and we began a discussion about what we were seeing, what the challenges and what barriers we were experiencing, and acknowledged that there was a need for something new, something unique that could support these individuals in a manner that traditional services were struggling to do so successfully. And out of those discussions, CBIT was born. And CBIT was born out of Cambria County recognizing that it wasn't necessarily about a lack of services in Cambria County, but really about the absence of the right service to support these individuals. One of the barriers to this type of program, and CBIT, or community-based intensive treatment, is the lack of reimbursement that existed. There was a lot of resources invested in it. Many of the components, you would have case management involved, you would have psychiatric services involved, partial hospital, potentially psych rehab. All of those standalone services needed to be brought to the table because we wanted to ensure that it was collaborative, comprehensive, and inclusive of all community-based services that were available to the individual. As many of you know, one of the challenges with that in a managed care environment is that you can't bill for 2 services at the same time. And so that oftentimes could become a barrier for a provider's ability or willingness to participate in that program. The county and Knowlton Diagnostic made a commitment that we believed in this model. We believed that we would see the benefits of supporting individuals in this manner. And so regardless of reimbursement, we moved forward with supporting and implementing this model. Although reimbursement and the cost of the service is important and is vital to the survival of a business or organization, we really made the focus of this program on the human element. We wanted to ensure that the community tenure of these individuals, the quality of life that they were experiencing, and to help avoid unnecessary or avoidable community inpatient hospitalizations and or state hospitalizations that were restrictive and oftentimes involuntary, which does not, as we all know, does not promote member engagement or participation in their own recovery. So CBIT came to be in 2013. It was a weekly huddle meetings that would occur with participants from the county as well as Knowlton Diagnostic staff. Those meetings would happen once a week to kind of brainstorm what was going on, to problem solve, to discuss plans moving forward. And then throughout the week there was a lot of back work that was happening, whether it was through case management or one of the components of it was kind of a navigator of sorts of the whole program, and that individual was an employee of Knowlton Diagnostic, and they would kind of make sure all of those pieces were connected and the communication was happening to ensure the success of the individuals who were participating in the program. There was I believe in 2015, 2016, we took a look at the data. And really this was an anecdotal look at it. We didn't necessarily track all of the details, but we included everybody who had participated in CBIT, and it validated what we believed about the program, was that it was making a difference in community tenure and the length of community tenure for individuals who were being discharged from the state hospital. CBIT was never designed for individuals to stay in it permanently. It was based on how they progressed and engaged and linked to natural supports in the community. But many of the individuals who had been involved in CBIT at the beginning had been successfully discharged and continued to maintain community tenure. I want to be transparent and truthful. We included all data, and we unfortunately did, even through the course of CBIT, lose an individual. He successfully took his own life. But we didn't exclude that data because we felt that it was necessary to be transparent and honest about the model and what we were trying to accomplish. The real focus of CBIT, I think I've kind of tried to establish, is it really was about to avoid the recidivism and to limit the immediate need for inpatient psychiatric services, to have this team that is working with the individual to support them and knowing what's going on and that the things are not falling through the cracks. The other piece of it is about the quality of life of the individual, and we really wanted to break down any barriers that existed. We wanted this to be a community. We wanted this to belong to the community, that this was a community initiative. And that any provider can participate in this. It was not limited to just the county or Knowlton's, or all we wanted to ensure was that the buy-in. If a provider that was providing the services came to the table, we wanted a commitment from them that they would be committed to the program, that they would be collaborative and cooperative in serving these individuals. Just as far as why is CBIT successful and why would that make eCBIT successful, we wanted to ensure that we made sure that we followed the primary principles of ACT. We participate in weekly huddle meetings and collect the necessary data to ensure the fidelity of the program. We really focus on diversion and intervention to try to prevent inpatient hospitalizations. It is very person-centered. The individual is part of the discussions, part of the plans, part of what goals are being worked on and what direction. This going back to what our mission was, what our focus was, which is the human element. We want the person to be engaged in the process. This is about their life, their recovery, and we want them to be part of that. We incorporated crisis intervention services into the CBIT model, so that they could be a resource and a tool for individuals who they could work through issues with crisis rather than automatically present to the emergency room. CBIT was to be comprehensive. We also evaluated and looked at the physical health aspect of things, because we wanted to make sure that not only was the mental health being addressed, but the physical health was being addressed as well. And the team approach was very important to us. I can't overstate that enough, that this really was about collaboration and partnership, and it was not to be about who owned the program or that it belonged to anyone. It belonged to the community, and that we were there to support one another in helping this individual maintain their community tenure. The design of CBIT really is to use in-service plans and then be innovative with those plans to try to maximize the benefit and the resultant benefits for the members that we serve. And by having this all-inclusive model of service and care, it does limit the fragmentation that often occurs in traditional standalone services. So today's presentation really is about eCBIT, which is Enhanced Community-Based Intensive Treatment, and how did we get from CBIT to eCBIT. As the county, and when I say the county, I'm not saying the county government, I'm saying as Cambria County and Knowlton Diagnostic and other community partners, we recognized the benefit and the success of the CBIT program. And although we got a lot of positive feedback from managed care and otherwise about CBIT, that we still were running into a wall or a barrier when we saw the next level of this would be to make it an in-plan service. So in 2018, we presented a lot of information and data to our Health Choices managed care partner, which is Magellan Behavioral Health. And they did their own data analysis and review of it, and they liked the idea of it, they saw the benefit of it, and so they saw it as an opportunity to make it a value-based model. And so eCBIT was then born. We have slowly transitioned the individuals that were in CBIT. We don't have nearly the degree of individuals being discharged in the numbers that they were from the state hospital, but we can still separately maintain the CBIT model separate from eCBIT. eCBIT really is to focus on the community hospital as opposed to the state hospital, which is by history why CBIT was developed. And so our Health Choices partner Magellan saw eCBIT as a way of developing a value-based program. They saw the value in it, and they saw truly the benefit of it in reducing the expenditures on higher levels of care, but the most important part, which is promoting community tenure and keeping our members in the community.
Hi, my name is Monica Collins. I'm the Director of Delivery System Transformation at Magellan Health. I wanted to give you a little bit of background about how Magellan became involved in the revised CBIT model, which we'll be talking about as Enhanced Community-Based Intensive Treatment. So Cambria was a new county to Magellan as a behavioral health managed care organization in 2017. And one of the things that Magellan already had in place was a value-based model that went across all of our inpatient providers in all of our other counties. So whenever we started working in Cambria County, we saw some of the similar pain points with inpatient and community-based providers that you would see in other counties. Often there's fragmentation, there's a lack of communication, difficulty getting follow-up points, and some of the main reasons that a managed care organization is involved in that. So we started in the county working with the inpatient provider. So this is prior to really understanding a lot about the existing CBIT model that Dr. Knowlton and the county had originally put in place. And what we kept hearing from the inpatient provider is that they couldn't get follow-up appointments, that they had this group of members who were frequent readmitters, and no matter what they did, they couldn't meet the readmission rate or the follow-up expectations that they had. So we took that to heart and started to do a little bit of digging into the data. One of the main things that Magellan does whenever they're implementing a value-based model is spend a lot of time with the providers in the community. And I had mentioned on the previous slide that we were hearing from the inpatient provider in Cambria County that they were really having trouble with this group of members who were frequent readmitters. They were unable to get follow-up appointments. So we started to dig into the data to really see, you know, what are the struggles from that point. So we looked at inpatient admissions for mental health. We looked at substance abuse residential services and really looked at how can we work with the hospital and these members to impact those rates. And it became quickly apparent to us that we really needed to involve the community-based providers in this if we were going to impact these measures. So one of the things that Magellan already had in their inpatient model was a readmission rate, but also we had a risk-adjusted readmission rate. So essentially what that risk-adjusted readmission rate is we can say based upon certain characteristics about the provider and the members that they serve, they should be able to meet a certain readmission rate. So we were able to start working with that provider to say, your readmission rate is greater than 16%. But what our data is showing us is given your mix of cases that you admit, we should be able to work with you to get you down to a 12% readmission rate. So we started looking at what types of interventions would be able to support the inpatient provider to meet that readmission rate. And what we found was that the CBIT program that was already in place was really what was going to be needed to work with these members. And that's what we started building in order to move forward to the next step. So some of the things that, you know, we were really seeing that were a struggle for these members to have increased community tenure and not readmit were just the general fragmentation in the community. So, you know, it's a small community and there's, you know, not a ton of providers, but even with the providers that were there, there was a lot of territorialness for members, and it led to often fragmentation of care. So while the inpatient provider may have a really strong relationship with an outpatient provider, that relationship may not be as strong with other outpatient providers. And it's an open delivery system with member choice. So what we were seeing is if, you know, Dr. Knowlton's group had the existing CBIT model, but another community-based provider did not, and that member was already attached there, that they were finding that those were the members that may fall through the cracks. So we worked with the county and worked with Dr. Knowlton to say, you know, how can we really still offer member choice, get these members into the CBIT program and achieve the outcomes that we want to achieve? So, you know, we limited the program to 25 members and really built the program description around what we expected to get for the outcomes and made it a value-based model. So some of the outcomes that we really expected to get when we built the care model is that what we really wanted to see is that we had one provider that was having ownership of the member, really managing all of not only the health choices behavioral health services, but also coordinating with the physical health providers, coordinating with social determinant of health providers. The core team was comprised of dedicated positions, which included a psychiatrist, a nurse, a clinician, a case manager, and a peer. Additional team members may or may not include medical services, other behavioral health providers, hospital staff, county staff, housing staff, family members, pharmacists, primary care, and it also included at this point the Magellan care manager. Really the intent of this was that the treatment team is multidisciplinary. They're always on the same page, care's coordinated, it leads to less fragmentation, less follow-up, and it also allows for the community-based e-CBIT team to have consistent conversation with the inpatient provider and reduce the fragmentation and ensure the follow-up. Some of the other components of the e-CBIT care model included weekly team huddles, and the intent of the team huddles and extended team meetings were so that there was a lot of conversation that both the core team was on the same page with the members, with that psychiatric oversight, considering that physical health component. In the weekly huddles also included the Magellan care manager, so that again, keeping everyone on the same page and allowing for that consistency and lack of fragmentation. We really call this our elbow support model. So there may be times that other providers would have been involved in those weekly team huddles, but it was really dependent on the member wanting that and also including those other providers, knowing that they existed. Some of the other components of the care model included electronic medication monitoring whenever a member's agreed to it. Big piece of the model was screening and outcomes tools. So whenever we built the model, we knew what we wanted to get out of it and we knew what the expected outcomes were. So we started from the beginning in saying, how do we measure these as we go along and how do we truly relate them back to the model? So those were a big component of it. Some of the other tracking measures that we had in the care model were things that we would look at on a regular basis. So not necessarily outcomes tools, but we had some utilization expectation and some ongoing pieces that needed to be considered. One of the things that I want to take a second to talk about is really the role that the Magellan care manager played in the e-CBIT model. So there was definitely a lot of work between the inpatient provider and Dr. Knowlton's group. One of the advantages to having a Magellan care manager involved was that we can see things that maybe you guys can't see. We can see things in the claims data. We could see if a member was already attached to another provider. So we really could support the model in terms of having the conversations with other providers or outside of the e-CBIT team, because we had a line of sight into some of the other data that was there. Some of the ways that we did this and the ways that we got members on the team that were the right members and helped coordinate that was that initially when we started the model, we actually had one assigned care manager who all the referrals were coming through that care manager. So she was already working with the hospital. So she was able to catch members when they were in the hospital and help the hospital make that referral to e-CBIT. She also played an important role in terms of logging and tracking the members when they started e-CBIT. So claims data is often, at a long lag and it's difficult to find actionable data. So with her tracking the members who were inpatient, looking at who the members were already attached to, then we were able to start logging them, make sure that they were referred to e-CBIT, and we were able to start tracking their data sooner than if we would have waited for claims data. Our Magellan care manager had a pretty clear process that she was regularly looking at readmission reports to make sure that we weren't missing any folks. She was looking at a weekly census report And she would bring that report to our internal, what we call rounds, which is when we meet with our psychiatrist and our clinical team has supervision. So our psychiatrist was able to look at the profile of the members also and make sure that, you know, they were meeting the criteria. It was a sound referral, help sort out on any suggestions that maybe they would have had, also to include things, you know, from the physical health side. They were able to weigh in on, you know, some of the medication thoughts. And we had lots of opportunities that way to also have the psychiatrist on the ECBIT team and the Magellan psychiatrist partner on cases that were potentially more difficult and needed more oversight. So I'm going to move on to the metrics and measures of focus, and we can talk a little bit through those. So as I mentioned, we had some ongoing metrics that we were looking at. So what we really did was we looked at what are our ongoing indicators for how we're doing in the model based upon some of the care model expectations in the population that we were targeting. So on an ongoing basis, we were able to look at 7-day follow-up. Mostly what we wanted to see with 7-day follow-up is that were members who were being discharged from inpatient being engaged with the ECBIT team within 7 days, but we also measure were they being seen within 24 hours of discharge by a member on the ECBIT team. So there was a dashboard built to monitor that. Some of the other pieces that we looked at were average number of visits, sessions, and units per member per week per month. So we had some expectations of how often members should be being seen. So if they were, you know, if their functional impairments were rising to the level that we believe they were, and they were regularly readmitting, we believed that they probably needed about 2 to 4 hours a week of services across the treatment team. So we have been, and we did monitor that on an ongoing basis. The things that were a little bit longer term that we looked at in terms of outcomes are, we look at community tenure. So we look at community tenure both short term and long term. And we were also, you know, checking were social determinant of health being measured on a regular basis. And then we were also keeping our eye on the hospital's readmission rate against their case mix readjusted admission rate. So one of the interesting pieces with this model is, while we were building the value-based model and supporting the hospital to meet their goals, you know, it was really important that we were clear that it was the ECBIT team who was helping the hospital meet their goals. So we needed to make sure that we were able to also, you know, include the ECBIT team under a value-based model, because that's really, there's value coming from there. And they were the ones that were supporting the hospital and really impacting that rate that we needed to see impacted. So what we found from our data analysis is that we needed to come up with the members who were the frequent readmitters. So what we found is that tended to be members who were 18 or over. They were already enrolled in health choices. They were not a primary diagnosis of substance use disorder. And we were also looking at members that had greater than 1 admission, or really 2 admissions within the 6-month period. The main thing that we tried to call attention to was that the members also had to have severe functional impairments that were a result of their mental illness. And that was why that they were regularly readmitting. So we worked with the inpatient provider and Dr. Knowlton's group to identify who these members were and how could we wrap around them to help them stay in the community. So essentially, once we picked the population that was driving our high readmission rates and our low follow-up rates, we really partnered to say, what is missing in the service delivery system that we can build through ECBIT? And some of the things that were missing were some of the things that were already identified in CBIT early on. But we were able to bring a managed care higher level data approach to it in order to focus the interventions on these members and also build what is a value-based model. So we built a clinical care model, and we also built a structure in order which to pay for the outcomes of that model. So the expected outcomes that we wanted to see from the model were more of your standardized measures that often inpatient and behavioral health managed care companies are held accountable to, are really your follow-up care. So we expected to see that our psychiatric appointments within 7 days of discharge improved. And then in addition, our psychiatric appointments within 30 days of discharge. If you remember, those were pain points that we were seeing in the data at a higher level that said, hey, we need to partner with these providers different in order to impact these. Some of the other expected outcomes were reduced fragmentation of services. So, you know, we were expecting to see that through a member-centric care plan in which the eCBIT quarterback was the one who was owning that plan, outreaching to everyone. They would come to the meetings on a weekly basis along with the Magellan care manager and ensure that everyone was involved in the treatment plan and the development of the treatment plan and knew who owned what in the treatment plan, of course, with the member involvement. We also expected to see an increase in engagement of these members. So, you know, a lot of times with the members, they may go inpatient, they'd come out of inpatient and they'd have a follow-up appointment, but they would never show up. So they were never really engaging with the providers for the follow-up. So the eCBIT team was going to see them when they were in the hospital, introducing themselves so that they had that connection whenever they did go to their official follow-up appointment, and they were able to check on them and ensure a smooth transition into the community. Another expected outcome was that we expected community reintegration or community tenure to increase. So, you know, what we were looking at even initially was that we wanted to see longer periods in between an admission and a readmission. And then we started to look at, you know, was community tenure over a 90-day period increasing? Was community tenure over a 6-month period increasing? Eventually, as we get down the line, I'm sure we'll want to look at community tenure after members are discharged from the program. One of the other expected outcomes that we had was really delivery system transformation. And when you think of delivery system transformation, you really think of delivery systems working together. So that if you have a member moving from level of care to level of care, inpatient to outpatient, that, you know, everyone knows what's going on with that member. There's truly coordination across that member versus having these pods of services that aren't talking to each other, and that's where members really fall through the cracks. So I'm going to move on to a little bit more the detailed metrics and measures of focus of how we tracked throughout the program progress and effectiveness. So I mentioned some of our expected outcomes were going to be 7-day follow-up. So we had a dashboard measuring follow-up. We had a dashboard measuring 30-day follow-up. Again, I mentioned that we wanted to see that gap between admission and readmission decrease for the hospital. So we were measuring that on a regular basis, and that was an important piece of the hospital's value-based model and an important piece of how we knew that eCBIT was successful, because these were the members that the hospital was saying they were truly struggling with, and this is who they could not meet their readmission rate with without having that support. Community tenure is something that is measured on a regular basis. We have a dashboard that looks at that, and then we also have a longer term dashboard. And community tenure is essentially, a ratio of available community days against out of community days. And we were also looking at engagement and retention of the members. So, did we have members who were maybe being seen in the hospital and never seen again? Or were we seeing members that were being engaged while they were in the hospital by the eCBIT team, and they were staying engaged in eCBIT? Fidelity, and that's more a term that is used in assertive community treatment, which I'm sure that many of you are familiar with, but we were talking about really fidelity to the model that we built. So some of the things that we measured to look at the fidelity to make sure that A, we were engaging members, but B, that we were truly engaging the members that we set out to engage, was the intensity of the services. So we were really looking at the average number of visits, the benchmark that we set for that, the units per member per week and per month. And so that was an ongoing measure and a measure that we still continue to look at. Another measure was members who were seen within 24 hours of admission by an eCBIT team member. So we were able to develop a claims-based measure that we could take members who had an inpatient hospitalization and look for the eCBIT claim in order to identify if they were seen within 24 hours of admission. We also, on a regular basis, look at rehospitalization rates from claims, and we look at time from discharge to rehospitalization from claims. I mentioned earlier that a big piece of building the model is, if we built the model and we knew what we wanted to get out of the model, how did we know we were getting it out of the model? So whenever we built it, we started right at that point saying, what do we need to measure out of the gate? What are going to be the touch points for these screening and assessment tools? So the tools that we landed on that will be done for every member upon admission and at regular intervals thereafter were the PHQ-9. We also put in a tool for social determinants of health, which is very interesting. We have some interesting data on that. So over time, we're really hoping to see what kind of social determinant of health needs we're seeing that are acted upon that may lead to better outcomes. We included a quality of life. We also are using the ANSA, the Adult Needs and Strengths Assessment. And then another really interesting one that is going to be familiar to many of you is the assessment of transition readiness. So that's often used by ACT teams to, on a regular basis, meet with members to see if members feel they're ready for discharge and look at what needs to happen in order to get them ready for discharge. So it's a really important component of the model, and it's an important component of keeping us true to that integrated treatment plan. eCBIT care model.
Hi, my name is Ashlyn Zanke, and I am the supervisor for the eCBIT program. My role is to make sure that the program is effective by ensuring that consumers' needs are being met and that they are making progress throughout treatment. This involves overseeing the blended case managers and the wellness nurse that work directly with the consumers, and coordinating weekly huddles and treatment team meetings to increase collaboration on cases when needed. One of the ways the eCBIT team monitors for progress and identifies other areas for improvement is by conducting frequent assessments. As mentioned previously, we use several standardized scales to assess and address different areas of a consumer's life related to their mental health symptoms, treatment, and quality of life. The Assessment for Transition Readiness Scale, also referred to as the ATR, is used to monitor for a consumer's readiness to transition into a lower level of care. So for example, when a consumer is ready to discharge from eCBIT services, they can transition into regular blended case management services and continue with their outpatient medication management and therapy. This scale is completed on a biweekly basis by the consumer and the blended case manager to track their progress. The questions asked are related to the consumer's treatment compliance, needs, and resources to address those needs. A score of 50 on this scale indicates that a consumer is ready for discharge from eCBIT services. However, this is always used in conjunction with assessments by the clinical providers and other treatment team members, because sometimes a score of 50 doesn't mean that all barriers or mental health symptoms have been resolved. Here you can see that the scores do steadily increase over time, and as early as week 13, some consumers do hit a score of 50, which means that they're ready to be discussed for possible discharge. Another assessment utilized in the eCBIT program is the social determinants of health, otherwise referred to as the SDOH. This scale is completed on a biweekly basis by the consumer and the wellness nurse to identify any environmental stressors or barriers that could be inhibiting recovery. Questions asked on this tool are related to food, shelter, finances, and access to needed services. Anytime an item on this assessment is identified as a possible barrier or concern, it is relayed to the blended case manager so that they can help the consumer address the need and resolve it as quickly as possible. As you can see here, our graph shows that the scales do significantly decrease over time, indicating that barriers and concerns for the consumer are addressed and resolved in a timely manner. Another assessment that we use during eCBIT services to identify other areas for improvement is the Patient Health Questionnaire, or the PHQ-9. This is also completed on a biweekly basis by the wellness nurse and the consumer to identify concerns with mental health symptoms. Questions on this assessment are related to mood, appetite, and sleep, and any concerns that are identified on this scale are relayed to the appropriate treatment team provider so it can be addressed in follow-up appointments. The goal is for this score to decrease over time so that we can see an improvement in mental health symptoms. As you can see, our scores do fluctuate, which could be attributed to day-to-day changes in mood. However, they do significantly decrease over time, indicating that mental health symptoms have been addressed and improved. Finally, we also utilize the Quality of Life Scale, otherwise referred to as the QOL, to address and track the consumer's perception of how they feel they are doing throughout treatment. This looks into the consumer's perception of their overall quality of life and well-being. This scale is completed on a biweekly basis with the wellness nurse and the consumer, and again addresses areas of the consumer's life to see how they perceive they are doing. Questions here include areas related to peer and family relationships, employment and recreational functioning, community involvement, and independence. Here you can see that scales do fluctuate similar to the PHQ-9. However, over time, they do significantly increase, meaning that the consumer's perception of how they are doing has improved.
One thing that we do with every client coming into CBIT or eCBIT is they get an ANSA. They get this ANSA, which is the Adult Needs and Strengths Assessment. And the purpose of this is to look at different needs in different domains, different strengths and domains, and mental health risk. And they get this at the beginning, also during and every 6 months, but also upon discharge. So we have pre, peri, and post data for comparison purposes. But if you look at a typical CBIT client coming in, they have the highest level of needs compared to other types of programming. And we show a comparison here with like adult partial, case management, mobile mental health, evaluations, and outpatient therapy. Now, not everything is a clinical program like BCM or case management, but we wanted to show you a comparison of how severe the eCBIT client is when they enter the program, with an average of 9 treatment needs compared to the outpatient individual that has 4 treatment needs. This would show that discrepancy and why we're looking at a level of care and how to transition from a higher level to a lower level. But we can also see the pitfalls of trying to go from a high level of care like CBIT to outpatient immediately. There's where you'll see the failures in the readmission and also more problematic. However, getting stuck at one level of care is not good either for anybody. So we see though that during ECBIT, they drop their level of needs by 1.5 treatment needs. When they drop down to these treatment needs, this now is an opportunity to transition into a lower level of care. Now, why I bring up case management can be a great assistant and a glue type of program into this to assist with decreasing readmissions. So what you'll see is when you're engaged with case management or maybe mobile mental health, we start to decrease their level of need, but also we get them into a more appropriate level of care, continuing in the community, but also integrating them into the outpatient. And that would include psychiatry or therapy, but also remaining some community-based like case management and peer support, and maybe a mobile mental health therapist. This really can assist that person to step down to the next level, and that'll be the next part of our project as well to describe that. So what we see here is we see the individuals coming into the ECBIT program and their needs profile. If you look at the top graph, what we have is the most prevalent needs and the top 6 problems that are presenting in risk behaviors. As you can see in this and may expect is they have significant anxiety and depression, along with some attention issues, anger control, adjustments to trauma, and psychoses. And the most prevalent we're looking at there are the anxiety and depression. And what we see throughout the program is you'll see a drop in the risk and the needs. And if you look at the anxiety and depression, they're dropping rather significantly from entering the program to exiting the program. The one that remains still problematic at the end is adjustment to trauma. This is one of our focus areas where we're now training staff to really start to target trauma and that adjustment to it. Now let's move down to the bottom graph of functioning. The people coming in, now the higher score in the blue actually means less functioning. So they have a higher needs in their functioning area. So let's look at social. These people tend to have less social functioning skills, and upon leaving ECBIT, they have more functioning or a higher level of functioning in things like social and interacting with peers. They have a better recreational functioning level. Their sleep is improved, which will tie into depression and anxiety and other mental health issues. But we do see an increase in family functioning conflict. And we're not sure exactly what this may pertain to, but as people get healthier, they start to interact with their family, and we may need to look at that. So that's another area that we'll be looking at examining to target for improvement with the individual. One of the most important things, and also a wonderful outcome in ECBIT with the individuals, is the strength development. We measure strength, as we told you earlier, is really looking at a strength-based approach to treatment as well as a recovery-focused. We need to understand our strengths so we can utilize them, develop upon them, but also help improve other strengths that are needed to have a well-rounded person. And when you look at this slide, let's look at the 3 that are on there. We're looking at resiliency, optimism, and resourcefulness. And if you look at this, the people that are coming in have very low resiliency. And we know this is an important one in treatment and recovery as well as progress. The other one is optimism. If we don't have a good outlook on life, it's really difficult to decrease our depression, which is also tied in with anxiety. The other one is resourcefulness. If you have very low resourcefulness, few opportunities to engage with others, it can be very difficult to recover. So a focus on this was extremely important in ECBIT, and that's what we did. And you'll see the outcomes of this. These people were showing significant improvement in all 3 of those very important areas of recovery. The next slide here that we're going to look at is inpatient admissions prior to ECBIT and during ECBIT. This is very important because part of the project was to really look at tackling those HEDIS measures and trying to reduce the readmissions to inpatient hospitalization. And we've all heard about this over the years with the state and the county, is we really want to see a reduction in readmissions, or sometimes as we see these people will fall into this rut of going into the hospital over and over again. So what we saw prior to CBIT with 41 members that we measured is they had a significantly high hospital admission rate with 72 hospital admissions for these 41 members. Once they enter ECBIT, we see a significant decrease in the utilization of hospitalization. and you'll see this drops to 37. Now, the reason this is we can know that we're providing significant support, a lot of resources, different connectivity, urgent appointments to psychiatric care, medical care. These people are getting a lot of support during this programming, and this is vital. And you've heard this with Ashlyn and others, is engagement. One of the most important factors that we discovered in this program was engagement. And we teach our staff about engagement. It's not enabling, it's engaging. And we engage these individuals so they stay in tune with their treatment, and we see the outcome here, decrease in hospitalizations. They have access to care, they have access to people, they have access to support. Huge success for this. The next thing you're going to look at here that ties directly in with the hospital admissions is community tenure. Community tenure is something that we were all excited about, is because a lot of the people were not staying in our community. They were either in state hospitals, public hospitals, they were in different group homes, LTSRs, different programming, but rarely staying within the community sector. And you see in this program with eCBIT, prior to that, 79% of these 41 members were in community tenure. After entering eCBIT, that jumped up to 91%. This is pretty amazing to see an increase in community tenure. And another one of the target values that the state and managed care and the counties wanted to see. And we now have a program that has actually tackled that and demonstrated quality improvement. On this graph here, what we're looking at is per member per month inpatient admissions, pre-CBIT and during eCBIT admission. So we can see a 0.52 per member per month have inpatient admissions before eCBIT. Now this will correlate with the other graphs, of course. And then you see after they enter eCBIT, it drops to 0.17. Again, a significant per member per month inpatient admissions that we need to examine and really see the benefit of this type of intervention in the community that's rather intensive and also very engaging, and that's what you'll see with the success of this program. This will be a question a lot of people have, is how long are they in the services? Interestingly, in looking at this level of care, in a community-based program, one may think that they're in there forever, and they are not. These individuals are staying in the program about 21 weeks or 153 days is our average length of stay. And what you're seeing with the data that Ashlyn has presented is that we're seeing that these individuals are ready to transition to a lower level of care in this time period. This is pretty significant given a lot of the programs that we've compared this to, such as ACT or such as partial hospitalization programs or other intensive programs. And these individuals stay community-based and in the outpatient settings.
So one of the things that I had talked about earlier was value-based purchasing. And I know one of the things you guys are probably wondering is, how does this fit under value-based purchasing if we're not talking about paying for it differently? So from that standpoint, just to give a little bit of a background on value-based, whenever we at Magellan build a value-based model, we often start with the care model and the outcomes we expect to get from the care model, and then we decide how we're going to pay for that. So that's why the payment model is at the end of the presentation, coming a little bit later, but did want to call that reason out. So one of the things that we had realized is that there was a lot of work on the eCBIT team, right? So a lot of not downtime, but administrative time that was absolutely critical to the model, and engagement time that was absolutely critical to the model, but in a fee-for-service system was not reimbursable. So it was really important to us that we started out making sure that we were able to pay for things that add value that in a traditional fee-for-service system may not be able to be reimbursed. So what we did do for that initially to get started, because we didn't have any history in order to be able to build like an alternative payment arrangement or a rate that would be enhanced enough to offset that is we worked really closely with Dr. Knowlton's team around, you know, the time that would be spent in huddles and, you know, how much time that was that the team could have been doing other activities. We also spent a lot of time talking about engagement because we were really expecting the eCBIT team to go out and meet with the members in the hospital, but the members may not have wanted eCBIT. So if we're dispatching, you know, providers to meet with members, you've got, you know, travel time and just time in general meeting with the members that wasn't at that point reimbursable. So what we really did was we built an enhanced case management rate. Because the case manager was really the quarterback of the eCBIT team, and keeping in mind that the quarterback was the one to pull everyone together to make sure that the care plan was being implemented. You know, really the one to get the information to the psychiatrist, the one that was working with the Magellan care manager. So they were the one who was always carrying the ball or the heavy lift for everything happening. So that's essentially how in year one, we set the payment structure and included it under a value-based model, is that it was an enhanced rate for case management to offset some of the administrative costs, but we knew that those activities needed to happen and we knew that we needed to reimburse for them or we wouldn't get to the outcomes that we expected. So we definitely learned some lessons, although I think many of them seem less painful hindsight. We've certainly spent some time thinking through them, talking through them. And I think the main lesson learned, and it comes more from the boots on the ground team, is the more a client participates and is engaged, the more successful they will become. And this goes back to those, what I was calling administrative value add components that we knew had to be there and we needed to figure out how to pay for those. And that was really the engagement. And I think that has been a big lesson learned, that we did have to spend a lot of time early on saying if a member said they didn't want the service, there was a fine line between a member not wanting the service and truly engaging the member and understanding, was it their symptoms of their mental illness that was preventing them from engaging, and how to, re-engage them and be respectful of, their needs, their right to choice, and all of those pieces. So that took some time. I believe Dr. Knowlton himself spent a great bit of time in supervision around engagement techniques. One other thing that I wanted to touch base on was opportunities. So you're probably asking what's next. You heard Dr. Knowlton go through, the outcomes that we've seen thus far that honestly, I think we were hoping would be there, and we kind of knew they'd be there, but we're really seeing them. So it's excited, and it's made us think, what can we do next with this, right? Like, how can we expand this model in order to strengthen the delivery system? So probably the main thing that we want to take a peek at is really, could this model be used as a diversion model? Right now, we're catching folks after they're going inpatient. So they're already a readmission at that point. So, is there a way that we can partner with not the inpatient unit, but maybe even the emergency room or the crisis provider in the community, that we actually could truly have a diversion program before members have to get to the point of multiple admissions? The other thing that we are currently working on, and it is a big opportunity, is integrated reviews. And when we say integrated reviews, we're really talking about how do we involve the physical health plan and the Magellan physical health integrated care team into the reviews with the providers. So we have a lot of insight into other services, medical services on the physical health side that members get, and we have a profile of those members. So we're working closely now with Dr. Knowlton and his team about how can we use those profiles within the eCBIT team in order to strengthen treatment and even partner with the physical health providers around getting, really strong outcomes for the member as a whole. And then the third and final one, which we're all really excited for, but we still want to take a little bit of breath on it, is expansion into eCBIT for a special population. I think with some of the things we've seen with COVID this year, we're all a little bit reticent to say that we need to expand the eCBIT model outside of the current population, because we're not really sure, what we're seeing in terms of member needs, whether it's coming from some of the, struggles with COVID at this point. So anyways, long story short, I think you could probably, look for some revised eCBIT models down the road. I think we all have some ideas about what those might look like. We're just feeling like we need some stronger data in order to get past COVID and really determine if it's an eCBIT model that's needed. Payment, there's a lot of opportunity for payment here. And we talked about, where we're currently at now is an enhanced case management rate. But really where this model needs to go is potentially into a bundled rate. So we're paying one rate across all the services for one member rather than kind of the widget fee for service standpoint. And also really looking at, with these outcomes, if we're reducing readmissions and we're increasing follow-up and members are having, episodes of care that are potentially shorter and better outcomes with a different kind of clinical model, and that's because of the eCBIT model, we need to look to share those savings with the eCBIT provider and the team. Because I mentioned earlier, if we're impacting the hospital's readmission rate and the hospital's follow-up rate, right? It's not them really doing it. It's the eCBIT team. So we want to make sure that whenever there are shared savings and there's rewards, that we're equitably sharing those amongst the folks who are doing the work. So right now we have started to look at the data and are really putting together a bundled rate and some potential shared savings for this model. So I think, should we come back and have some information on the model at next year's RCPA, you could probably look for some continued outcomes, maybe even a model for a different population, and we'll be able to let you know what it's looking like with a bundled rate and some shared savings at that point.
All right, so Tracy, let's talk about how we started CBIT actually back in 2008.
I think I remember the exact was a phone call, and you were in the woods somewhere with your boys. I said, hold on a minute, I gotta make sure I'm not burning something down. But no, it really came about, we were really struggling with individuals coming out of the state hospital and them not being able to maintain community tenure. So the focus really was on the state hospital population and keeping them in the community. And although we have a lot of great services in the community, they were all standalone. And so there wasn't that comprehensive approach to supporting individuals. And I think our conversations, we acknowledge that that really was the challenge, was how do we kind of wrap ourselves around these individuals to ensure the best outcomes for them.
And if I remember this correctly, there was about 6 patients from Torrance State Hospital that got discharged. Difficulty was getting them appointments. With psychiatric time, no one was willing to take them in at that time, and it led to that challenge.
Yeah, it was, some of it was the ability to accommodate them because of the capacity of their program, but some of it was, we all acknowledge that this is a difficult population. It's not willful a lack of cooperation, more because of their illness, that they are not always the most compliant individuals, or because if a day or two goes by and you don't have that touch with them, they kind of drift off. And so that was kind of a challenge, that by history they didn't have a good experience with that provider because of non-compliance, and so there was a reluctance to serve them then.
I think what was fun about this too is that it really was just a collaboration. I would say you and I, but really if you look at the county and a provider, we were trying to find innovative approaches to deal with this situation and problem. And I think you probably touched on this earlier on, but you know, we had applied to be an ACT program and realized we weren't a big enough county to be an ACT program. Right. And we didn't have the census, but we took a lot of those key elements in the fidelity part of it and built this program really from the ground up.
Absolutely.
And created a great model to decrease those hospitalizations. And I think Kimberly actually was one of the ones too who works for the county, was surprised that we weren't having people go back to Torrance immediately, which was a pretty significant problem. At the local
they weren't
hospital.
even going at the community, they weren't winding up in the community hospital. And we were honest with the data. We were honest and said that we are not going to have 100% success. Yeah. But I think it validated for us what we felt would be the case, which is that we were very successful. The individuals that we served were very successful because it was a buy-in from everybody. Yeah. And there was never an effort, I mean, it really belonged to Cambria County. It was always inclusive of any provider who wanted to come to the table. All that we asked was that there was that commitment to it, because the commitment is what makes it successful.
And that is true. It was really the integration of anybody, everybody that wanted to help that consumer, which I found, you know, a lot of fun, was that we just were trying to engage anybody that would have the client engage. I thought that was a lot of fun too to do, and definitely challenging.
Right, but and as we went along, I mean, it really started as kind of the county and Knowlton's, and it wasn't to exclude anybody, but this was not a reimbursable service. And so it really was about a passion about what we were doing, and really improving the quality of life of these individuals. But as time went on, we just kept adding more. It's like, oh, crisis would be a great piece to add to this. And I think everyone, as they came to the table, got really excited about it, because it was a far more, although we weren't getting reimbursed for it, it's far more cost effective and successful sometimes than even a very costly ACT program.
It was surprising, the fact that we weren't being compensated for it. It was more of just a project, little pilot project. But it was funny, the managed care indicated that they actually were saving money. Right. Due to this model.
They said, thank you, keep doing that.
Yeah, thank you, keep doing it. And really this did unfold, and not until Magellan got here, what was it, 2018, that we turned it into eCBIT, and this was from Magellan, and it just meant enhanced, and they did add a lot of unique elements that moved us into the value-based payment model era. Which I think is great. And to have a partner now with the county and the provider of the managed care, the payer, is definitely, I think, what's made it so successful. But, you know, Ashlyn, you kind of are the eCBIT, and you helped implement it. And I think you would agree one of the biggest components was engagement. People didn't understand it. I think they thought engagement meant enabling. And we tried to educate people, you're not doing a bad thing by increasing engagement. But if you just talk a little bit about eCBIT and how it started to be implemented as eCBIT rather than CBIT, maybe some of your challenges you had.
Well, I think we started with the core idea of that collaboration, really. So we started with the weekly huddles, more frequent visits with the BCM. Like you said, you know, a day or two can make a difference without contact, you know. So we dedicated specific BCMs to, you know, address this population and really increase the coordination between all providers involved. And I think engagement was a big struggle at first, but we've really learned to use all the resources we have to get clients on board. So if a blended case manager goes out and they're not receptive, you know, we can pull Magellan in, or the county, or someone they've had contact with in the past that they trust, to really get them on board with services. Mm-hmm. So I think that's really been helpful. And as we've gone, we've learned, you know, when we need to add in an additional treatment team meeting or something, when someone has more needs that maybe aren't being met by even our initial eCBIT model. So we've really tried to adapt over the last year and a half to meet each individual's needs just how they need them, you know?
It sounds like, too, you don't give up.
No,
on the client. And I think that's interesting too, to talk about matching staff with a client, which people didn't realize. And there's a conflict. What do you do with them?
Well, we start by sending the BCM out, and if it doesn't mesh well, we send another BCM out. And then if that still fails, usually I will step in, talk about what the conflict is or what the issue is. If we need to try another case manager, we'll try that. And then if we're still feeling like we're not connecting or engaging, then that's when we'll bring in, you know, Magellan. Chris Munoz has been a huge help to reach out to a client while they're in the hospital and really talk to them about what they need and what they're looking for in services.
So really that key to success, right?
And I think even saying that, and I think that's the important thing that people need to realize, is that this isn't about people never having a hospitalization. That is the reality of the disease. But it's that linkage when they're in the community hospital and that intensive nature of eCBIT. And I think you both touched upon it. At the end of the day, it's about that engagement. It's about connecting with the individual. And you're right, they say about you're enabling them. Really, I think the true mission of this is to empower individuals. Yeah. Our goal was never to keep people in CBIT or eCBIT forever. I mean, there is an end game in sight to move them on and for them to live as full a life as independently as possible.
Yeah.
I like what you're saying there too, the empowering, and we've been in the field too long maybe, but for long enough to know that we didn't want them to be stuck in this service level, to actually empower them and allow them to move on. And I think, you know, with Monica said too, the recovery focus vision that we had was truly recovery focused so they could move on. And we're not seeing these people again all the time. I mean, don't get me wrong, you'll have someone that goes through, right? You know, twice. Yeah. But they're not ending up in the hospital or the state hospital, which is odd. Yeah. And I mean, we truly are working ourselves out of a job, I think, to some degree, which isn't bad. And I think that's happening.
Yeah, yeah. I mean, it's great. We haven't seen a whole lot of people come back through. I'd say maybe 3 over the last year and a half. And one other thing that I think is a huge component is with the collaboration of care, when they are rehospitalized, making sure that the hospital knows what their treatment plan is, what medications they're on, and then when they leave the hospital, making sure that their outpatient provider has that information. That's a big gap that we've kind of noticed throughout this program that we've really tried to bridge.
How about like urgent care, not really just the urgent care appointments, but more getting these people in quickly and rapidly and dealing with any crisis quickly? Has that been a big part of this? Yeah,
and we've learned throughout. So we have a dedicated CBIT on-call phone now, so only our CBIT BCMs who are familiar with all of these clients, because they have such frequent services, deal with those on-call situations. And we do use crisis when we need them, but we really collaborate with them, so it's not just a call to crisis to say, hey, this person's in crisis, let me know what happens. It's, this person's in crisis, can you help to try to de-escalate? And if you can't, call us back and we'll make another attempt before we actually need to go the hospital route.
So it's a great diversionary and a reentry model, right? Yes. From the inpatient and avoiding inpatient.
Yeah, we actually send a list to Conemaugh Hospital as well, so that if someone presents to the ER without us knowing, then we can get a call for that as well.
Was there a big challenge for people understanding? Because it took us a long time for people to understand what CBIT was, and then were they like, oh, what's this eCBIT?
Yeah.
You know, it really wasn't that much different. It's I think the biggest piece is that partnership with the managed care company, and really the data analysis, the collection, and really drawing the picture of what, you know, the outcomes that we're seeing and we want to see.
Yeah, no, I would agree, because with that partnership with Magellan, again, if someone's hospitalized and we don't know about it, we get notified, you know, right away, and then we can go out to the hospital, see what happened and what we need to do while they're in the hospital to try to make the next discharge even more successful.
I think what's interesting when you look at the success of a program, like you said, do people know it? You know you're delivering a service when the hospital is also asking where CBIT is, and if they can help with that patient. And I know I was just on with the ER director yesterday down at the hospital, and he was talking about CBIT, which was fascinating. So the program has had that community impact that you hope it has, with the outcomes.
That's great. Yeah, I have caught them. I'll call on my cell phone, usually at least once a week, to see if a client would qualify for CBIT. So.